Hello, my name is Franny Sebastian. I'm one of the second year internal medicine residents at Ascension St. John, Detroit. I'll be presenting a case of acute limb ischemia, but who's to blame? COVID 19 or its vaccine? Introduction. Hypercoagulable state in COVID 19 and venous thrombosis have been commonly linked, but arterial thrombotic events are less common. There have been several reports of arterial and venous thrombosis associated with viral vector Janssen COVID 19 vaccine, which has been described as vaccine induced immune thrombotic thrombocytopenia. I am presenting a case of serious arterial thrombosis within a month of receiving the vaccine and contracting COVID 19 infection. This is a 59-year-old Caucasian male with past medical history significant for hypertension, diabetes, and Crohn's disease that presented with sudden onset left lower leg pain, swelling, and bluish discoloration. The patient had received J&J vaccine followed by a positive COVID PCR test 22 days and 11 days before presentation, respectively. On examination, his left lower extremities was tender, pale, purplish, and had absent dorsalis pedis pulse. All other extremities were unremarkable. Upon admission, he had a white count of 54,000, hemoglobin of 8.8, platelets of 444,000. His COVID test, a COVID rapid and PCR was positive. However, his COVID antibodies were negative. CMP showed an AKI with a creatinine of 2.3 and anion gap acidosis secondary to lactic acidosis, and also transaminitis with AST of 333, ALT of 203, and rhabdomyolysis with a CK of 1137. His D dimer was 117. So he had a CT angiogram upon admission, which revealed about 70% of occlusive thrombus in the left common iliac artery, uh, just distal to the bifurcation of the aorta, which you can see in the figure 1, and his left lower leg in the image next to it. Patient underwent emergent surgical thrombectomy and repair of popliteal artery with fasciotomy. Unfortunately, significant blood loss followed by profound thrombocytopenia prevented anticoagulation use temporarily postoperatively. Over the following 5 days, patient's platelet dropped from 444,000 to 50,000, and his hypercoagulability workup, including platelet factor 4 antibodies, were negative, serotonin assay were negative, ANA, beta 2 glycoprotein, cardiolipin antibodies, DIC panel, all were negative. On day 10 of admission, patient had absent left popliteal pulse and had to undergo a left above knee amputation. Following surgery, he had received enoxaparin, 120 milligrams BID, and was transitioned to rivaroxaban 50 milligrams twice daily for 3 weeks, followed by 20 milligrams daily for additional 3 weeks. His lower extremity pain improved and was later discharged to intensive inpatient rehabilitation. Conclusions: his profound hypercoagulability state resulted in large vessel arterial occlusion in the setting of COVID 19 infection and questionable vaccine induced immune thrombocytopenia on presentation. It is important to investigate these events immediately and start prompt treatment with a multidisciplinary team approach. Always remember to maintain an updated knowledge of COVID 19 and COVID 19 vaccine related complications. Thank you.